it's gotten to the point where people who get into recovery say, you know, I'm not allowed to say that I'm in recovery, you know, and so, and to a certain extent, 12-step groups have functioned as kind of a secret society to a certain extent. Now, I say that because I'm a person in long-term recovery now for 14 years, and I still attend 7 recovery-related meetings a week. To a certain extent, that's the medicine that I continue to take for my disease of addiction. But I can also say that it's a lot, I have to put $1 in at each of those places, and it's a lot cheaper than the prescriptions that I take right now for other things. So let me start off, and there's, again, addiction has historically been seen as a personal weakness and moral failing. And over time, the definition of what addiction is has varied, but it's expanded finally within the last 20 years. And this latest one that I could find from the American Society of Addiction Medicine is one I really like, and that addiction is a primary chronic disease of the brain. Motivation, memory, and related circuitry, all wrapped in one. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. This is reflected in an individual pathologically pursuing reward and or relief by substance abuse and other negative, actually, I would say, behaviors. Now, additionally, like other chronic diseases, addiction often involves cycles of relapse and remission. Without treatment or engagement in recovery activities, addiction is progressive and can result in disability or premature death. I think one of the things that I have come to appreciate because of this look at it in this way is that, unfortunately, historically, in this country, we have treated addiction on an acute care model, which means that we essentially kind of bring people in and put them through a period of detoxification. We then move them into a period of stabilization, accompanied with and often followed by education and things like that. But when it comes to the recovery component, we've historically sent them off to 12-step groups, which are not associated with the continuum of care, and severed the service relationship. We don't do that with cancer and diabetes and heart disease. You get regular checkups for periods of years afterwards with those, but we don't do that with addiction. And that's, but I will say that that's starting to change. But that's just kind of the historic thing. The other thing is there's been a lot more research because of these changes that have come. And a good friend of mine, T.K. Lee, who runs the National Institute on Alcohol and Drug Abuse, he's been a pioneer in looking at genetic factors and have found that genetic factors account for half of the likelihood that an individual will develop an addiction. Environmental factors, of course, also interact with a person's biology and affect the extent to which genetic factors exert their influence. And so he says that the genetic piece is 60% and the environment piece is up to 40%. So the neurobiology of addiction encompasses more than the neurochemistry of just getting rewards or seeking rewards. And it, you know, the whole thing about addiction is it centers in the brain. The frontal cortex of the brain and the underlying white matter connections between the frontal and circuits of reward, motivation, and memory are fundamental in the manifestations of altering impulse control and altering judgment and the dysfunctional pursuit of the reward. So once chemicals get introduced into the body, alcohol and drugs. If they're utilized on a regular basis, this transformation takes place. So again, I think as I mentioned earlier, the whole piece is that historically we have treated addiction on that acute care model, but we know today that it is a chronic relapsing disease. What it also is a pediatric problem. It's become so. And it's a public health problem today. What is not in debate is that today substance use in the United States is the #1 root cause of morbidity and mortality here. What is not in debate is chemical dependency results in behavior that is in repeated conflict with a person's values and goals. The individual's inability to function physically or mentally in a competent manner is often impaired. There's a lot of people who, again, because of the shame and stigma, think, they're doing this because they want to do it. They want to keep doing this because they've got a personal flaw or a moral failure in their character. But the bottom line is that as our chemical dependency expands, our free will contracts. And so it's an interesting dynamic, having lived through it myself. Overdose, this is the latest one, and I just heard this at a conference a couple of weeks ago, that overdose is the leading cause of death for persons under, I wrote this out. Overdose is the leading cause of death for persons under 50 years of age in the United States. That's what that should say. I just came across that. So let's talk a few minutes then about some of the ethical considerations related to treating people either with addiction and also treating people who are in recovery from addiction. I will say that you should know that there are 20 million Americans like me today who are in long-term recovery. My organization, the Indiana Addictions Issues Organization, only has 25,000 members statewide, but these are all people who are willing to stand up and say that they are in recovery. So obviously some of the common ethical violations when we're dealing with patients who are either struggling with addiction or in recovery from addiction come in the form of standards of practice, confidentiality, competent sexual conduct, and infractions of dual relationships, which also get a little complicated, can get a little complicated. The standards of practice sometimes happen in discrimination or billing and coding inconsistencies, showing up late to a session or too long of a session. That counselors in particular have some issues with that. Confidentiality are certainly being sure that you have valid consents and also recognizing what the limits are in the disclosures related to those consents. Certainly disclosing names or personal information in front of other clients is a common problem. Keeping confidentiality during group sessions or appropriate record keeping are all things that we have to approach very, very carefully in working with this population. Certainly inappropriate excessive disclosure, or being sure that we're staying within the job scope. I think one of the things about the whole addiction treatment and recovery field right now is it's continuing to expand. We're learning new things all the time. There's a lot of, I was also saying earlier that just in the 14 years that I've been involved in this field, the level of research has ramped up significantly, as well as the level of interest not only in the population but also in legislators. We're seeing more legislators and policymakers coming forward with actual solutions on the policy side, and legislatures coming up with projects and programs, but also money to actually follow that. I was, however, on a personal side, I was pleased that the president came out with his statement addressing addiction, but disappointed that there was no money associated with that. So we still have some work to do. And again, with you all on the front lines in some ways, you can be a really powerful voice for that as we move forward. So other things, sexual contact, these are all, I think, pretty straightforward, and you know, how long is a client really a client? Those things come up. Dual infractions, dual relationships refer to a situation where multiple roles exist between a counselor and a client. Examples of dual relationships are also in the client is a student, a friend, family member, employee, or business associate. And I think a healthcare professional should not be a client's sponsor. It's interesting. I had a situation some time ago where one of my healthcare providers that I've known for many years and also knew that I was in recovery disclosed to me that he had gone through treatment and was looking for a sponsor. And initially I began to work with him, but then we both realized that this was really not an appropriate relationship for us. And so he found I helped him find another sponsor, and I continue to see him at some meetings, and continue to see him as a professional too. So so those are part of the kinds of dual relationships that are not allowed. That's a violation. So professional and ethical issues unique to working with patients struggling with addiction. The first one is confidentiality. Clients have a special protection under federal law, which applies to anyone applying for or receiving treatment and referral. There are two major rules, 42 CFR Part 2, which is really the alcohol and substance abuse treatment confidentiality rule, and then there are also some HIPAA has some as well. The 42 CFR one, which was issued in 1975 and then revised in 1987, is really designed to help with the stigma that's related with addiction. And so it requires notification of confidentiality or consent forms, prohibition of redisclosure, basically saying, I'm sorry, I can't acknowledge whether someone is or is not in our treatment program. It also imposes restrictions upon the disclosure and use of patient records that are maintained in connection with the performance of any federally assisted alcohol and drug program. If a client requests that a substance abuse staff participate in case management while in treatment or during the aftercare phase, there has to be an authorized release form that's to be kept on file. And of course, no information regarding a client will be released without a signed authorization to do so. And when information is forwarded to another agency, it must contain the following verbiage. that it's a disclosure form saying that that this is what you have. It has to include in the process. So, HIPAA, Health Insurance Portability and Accountability Act, designed to ensure maintenance of health insurance coverage when you change jobs. But I think the main thing here is the last point: protect confidentiality and security of patient information. And again, at some point, I hope we don't have to worry so much about this if we can ever get addiction seen on the same level that we see the treatment of cancer and heart disease. One of the other things about confidentiality, that mere presence, and this is something I didn't really know, and I was telling my colleagues here that I'm really pleased to have the opportunity to put this together for you today, because I learned some things, and this is one of them: that mere presence in a chemical dependency facility is considered a diagnosis and cannot be revealed without a written consent, nor can it be denied. That was informed consent. Addicts entering, especially involuntary treatment, addicts entering treatment at various degrees of cognitive impairment. People get admitted when they're often severely intoxicated, and are cognitively impaired. So that is something to consider in the informed consent as they come through. So again, dual relationships of healthcare providers, counselors, or peer recovering counselors. They have to be careful about recovery groups and support groups and things like that, and of course, romantic relations are off the table. So, the aspect of 42 CFR forbids use of treatment information in prosecution and investigation unless court ordered, and then if it's court ordered, then federal rules and guidelines come into consideration at that point. Now, group therapy provides a little different type of situation. Interestingly enough, clients are not legally bound by confidentiality, but the counselor is responsible for confidentiality and must inform group members of limits to confidentiality. And then the duty to warn, to report or not to report, that is the question. Obviously, in certain age situations and HIV, that takes a special consideration on the confidentiality piece. So those are just something to consider as you are presented with some of these types of situations in your work. Also, the duty to warn, which is in the HIPAA piece, is those at risk, children of alcoholics, and genetically predisposition argument. So, this is a genetic. There is a genetic component to this, and so counseling family members or talking to family members about being careful to watch out for early signs. It's I wouldn't say it's a slippery slope, but it's a it's a difficult situation as you're working with families, and you have to use your best judgment as you, depending upon the height of the risk. I think there's no question that there has been a certain amount of discrimination against those who are seeking treatment in some ways. There's still some resistance to gay and lesbians and sex offenders, so that's just another area to carefully consider as you move forward, and seek advice from others in your organization who who have had some similar experience, or some of the legal folks in your organization as well. For counselors, which is where I got some of these things, is there are some values that should they have or not, or what they feel about how patients should be. Their 12-step model is total abstinence, but there are some other feelings that there is, people can control it, but should a recovered alcoholic drink socially or moderately? Again, these are kind of difficult topics to, again, 12-step groups are total abstinence, but these are, there are people, of course, who can be successful at controlled drinking, but at least initially, abstinence for a period of time that can vary per individual is something that can be explored, as long as you continue to have that relationship with them and see how they're doing and can monitor their vitals and physical appearance. The legalization of drugs for medicinal reason is a whole new field now that you're on the forefront of. Medicated assisted treatment is the biggest controversy right now in addiction treatment and recovery community. Again, because of the abstinence piece related to the 12-step groups, they basically say that we shouldn't use any sort of drugs and alcohol. We've had for some time, the only drug that was available for a long time was methadone for the treatment of heroin addicts. But today, we've got a whole plethora of new Vivitrol, Suboxone. There are a number of pharmaceuticals now that are being introduced in the treatment for addiction. And I think that, again, from an ethical standpoint, the 12-step fundamentalists would say absolutely not. Just not do anything like that. But I think, I'm part of the newer group of folks who are part of the Unite to Face Addiction movement, where we're looking at this as, we need to use all the tools in the toolbox, and there are going to be new pharmaceuticals. Our friends on the pharmaceutical side have found a new market in this, and so that I think, again, you all are going to be on the forefront of seeing these things as they come out now. And again, there's no question that the heroin epidemic that we're in right now has really elevated those issues. And so all the big pharmaceutical companies are powering up right now and are coming out with new things. And so again, you're going to be the test sites for all of that. So I wish you the best, and I think the other thing too is to keep stay in touch with those of us who are working in the field, and particularly with the recovery community. I think to get continue to keep us up to speed on that, because the medications are here to stay, and there are more coming, and it's going to change, cause some pretty fundamental changes in the whole culture as we move forward. So another thing that has kind of thrown the whole anonymity piece out is technology, and cell phones, because texting personal phone calls, that you can take any place, anytime, and then the free exchanging of personal information that takes place in social media. These are all things that can have some ethical considerations, and in some ways violations, hearing confidential information over a phone. So that's just really started, and that's also another piece that's going to be rolling out as we go along here, that there's so much more openness, or at least opportunity for openness in our society today than there's ever been before. And again, that's a cat that's out of the bag, and it's going to continue to expand as well. So that's always going to have to be something that we'll have to be aware of as we're treating patients. So I think I'll skip this one. So common issues that can come with not maintaining a good ethical approach is lack of self-care, certainly burnout, lack of training, and for those of us who are in recovery, not maintaining our own personal recovery. And the population that we deal with is often not the easiest one to deal with. That's just, that's part of why I hope that's part of why some of us do what we do. But these are the things that can cause you to kind of get lax in the way you approach your ethical considerations. I think we say in recovery that it's important for us to just step away and take care of ourselves on a regular basis, and that's not selfish. That's just good mental, maintaining good mental health. So here are some more, I think, 8 practices to avoid violations that, maintaining a strong supervisory relationship or a good supervisory relationship. Certainly taking advantage of trainings and workshops. I appreciate you being here today about these issues. Familiarity with state and federal statutes and regulations, because those continue to evolve, and certainly being familiar with your professional code of ethics. Obviously, good relationships and continuing and close relationships with other professional colleagues. Seeking their advice and help, particularly when you have a challenging situation that arises, and say, well, how did you handle this? Again, these are the kind of things that we do in recovery, because we're always being presented with challenges to our recovery, and that's one of the things I do in meetings is bring up what, it's kind of a professional staff meeting for me, I guess. I hadn't thought about it in those regards. So refer individuals who are not competent to treat, obviously. Don't need to go into that. And maintaining a working relationship with complementary health providers, and obtaining special training in dealing with suicidal or dangerous clients. So that's it for me. So at this point, I'd be happy if you have questions or comments that you'd like to make. I'd be happy to take those. Oh, yes, sorry. Okay. Yes, yeah, absolutely. I mean, that's for, I guess that's for, I forgot. Yes.
So Kim, one of the things that I know that many of our, particularly nurses do, but our practitioners encounter are the difficult patients while they're here for treatment, whether that be have to receive antibiotics. So I may be taking you a little bit different direction, but I'm going to use your expertise here. Sure. But they're here for antibiotics, and they have to be here for long periods of time, and the challenges that they face. So are there some ways, some things that we can do to help our staff as they deal with with difficult patients in the midst of receiving different kinds of medical interventions?
Yeah, I think one of the things that I have found, yeah, particularly on the recovery side of things, that one of the best things to help in staff development in this regard is role playing. Setting up situations where so that you have someone playing the part of a difficult patient, and then having a discussion afterwards. Okay, now what, because all of you bring your own skill. Everybody brings a certain amount of skills to the table here, and I think that having that opportunity to say, okay, here's how I would handle it, or I think that shared experience. That's what we do. With our groups is pretty much put it out there and say, here's what we're going to do. And sometimes, as I say, we have some people role play a particular issue that they're having about working with somebody in recovery or not in recovery, and then getting from the group some solutions, because it's a personal thing. It's in those cases it's always a one-on-one thing, and that's what makes it especially challenging. So yeah, absolutely.
Do you have any suggestions? Do you ever get family members that call that are really wanting someone to enter recovery, but that person seems to decline or be resistant to that? Do you ever have any suggestions for family members or caregivers that are really caring for someone, but ultimately are struggling because they really want that for that person, but that person may not be at that point yet?
Great question about family members, and yeah, I think that this brings me back to what I heard at the beginning, was that this is a family disease, and when I first heard that, I thought of the genetic component. That's what I was thinking of, but what I didn't appreciate until initially our son got into thing is that we became just as sick as he was, and in a different way, of course. Trying to rescue and in a way that we thought would help, or discipline too much or whatever. And so I think it's important that. And so one of the things that when even before I got into treatment, after he died, the woman who was the head of the treatment center that we went to, Helene Cross, had become a close friend of ours, and she asked to sit down with us and say, are there some things that, she said, I know you guys don't blame us for what happened, but are there some things that we might have done differently? It was an extraordinary question. And so we went back and thought about it for a while, and came back, and there were a couple of things that we talked about. And one of them was that when that the treatment center had a really wonderful program that taught us about the disease of addiction. and how powerful it could be, and what we were facing and things like that. But when it got to the recovery part, they just sent you off to 12-step groups. And again, 12-step groups are great, but certainly in Al-Anon, you're one of the things you're taught to do is to detach from your qualifier in ways, and and so when your qualifier is an adult, I can see that, but when your qualifier is a minor child, that's not ethical, so to speak. So we said Al-Anon really wasn't helpful to us, and so she suggested that we start a family support group, a parent support group, and there are many of those around. So I think the family needs needs resources as well. You can't just treat the child or the adult. They need to be referred to other resources to get that help, because they're suffering as well, in a different way, of course, emotionally and psychologically, but it can be just as devastating, no question about that. So definitely, encourage. Again, there are parent resources out there, and I have ones that I can direct you to as well. So I think that's a thing to do.
So we have two questions that came in from the broadcast site. I'm going to go ahead and give one of them, and I know we have one more question over here. Could you speak to the potential change in legislative practices for over-the-counter Narcan impacting our professional practices?
Well, that's a really good one. And that's right on the cutting edge right now. Justin Phillips, who is the person who has really pushed for that. She had a daughter overdose just a couple of years ago from heroin, and again, this is another one of those new tools in the toolbox right now. It is highly effective. I was at a conference yesterday and listening to a county prosecutor criticizing the hospital's ambulance team giving the same Narcan dose to the same person 6 times over a period of 2 weeks, and I thought, okay, why? He just said, why are we doing that? And I thought, well, part of it is that we don't have a good continuum of care that's getting that person who's had the Narcan into treatment and into some sort of, that should be, somebody who has an overdose needs to be moved into a treatment protocol, but we're not doing that right now. So having it available, I think, I'm not quite sure. I think it's too soon to tell. I think that's that's my answer. Is that it's we'll have to see how this rolls out. It's still pretty pricey. It's not accessible to everybody. We have a very large Hispanic population here in the state of Indiana, and they're woefully underserved on addiction treatment and recovery side of things, and so that's. But again, I think that's one of those things that we're going to have to see how that rolls out. We've got to take a look at how that gets used. I'm not sure. More will be revealed. I think that's the best I can do.
As you see it, what's the overall role for hospitals to play in this treatment of addiction?
I would urge hospitals to do all you can to, and thanks for asking this question. I would urge all of you to do all you can to broaden this continuum of care, and make recovery a full partner of the treatment. Let's treat this as the chronic medical disease that it is, and we're making great strides. There's a lot of good stuff that's going on right now, and having a alcoholic and drug addict talk to you like this and have the opportunity to tell you what I think is really special. So I appreciate that. But do what you can to broaden this continuum. We've got to do that because people are dying. We're losing an extraordinary amount of folks, and frankly, it's at its peak right now, and it's a question the deaths are not going down right now, so we're still at that point. So we've got to start thinking outside the box and doing all we can. So thank you.
So the next question, can you speak to ethics and resources for patients who are not complying with or seeking treatment, in particular facilities with limited mental health or substance abuse resources face challenges?
Yeah, that's a real problem. I think as happens in a variety of epidemics, which is what we're really in the midst of right now, you have a lot of, for lack of a better term, fly-by-night operations, and quite frankly, there are a whole plethora too of OTPs, opioid treatment programs, that are popping up all over. I think, and aren't reputable. Maybe I don't. And so we're at a point now, and obviously some of this has to be steered toward policymakers, but there's a lot of people who are taking advantage of this crisis that we're in right now, and don't have the proper continuum of care, and I fear are doing more harm than good. It'll be interesting to see as this rolls out whether a number of these organizations that have popped up, they have the potential of making the issue even worse at this point right now. So those of us in a professional position need to do all we can to be sure that the people that are offering treatment are reputable, and so some of that has to be legislators and other types of policymakers, but it's important that your voice be heard in that, because the policymakers only know what they hear from their constituents. They often don't have the kind of expertise that you do, and so certainly I would encourage you to stay involved in that way. So
I have some more broadcast questions, but I wanted to see if anybody here also had another question. Anybody here? Okay, so why are for-profit methadone clinics allowed to string patients along for many years, just collecting the $16 per day fee and not weaning patients off the drugs?
Right. Well, again, that's exactly what I was talking about in the beginning. Those are the ones that I'm talking about. Again, it's because this treatment for this disease is so siloed to a certain extent. You know, you have these small operators who come in and and they're taking advantage of the crisis. There's no question about it. And so we've got to hold our policymakers and legislators accountable for that. Raising that issue, but I think that's a serious problem right now. But again, it's because we haven't totally extended the continuum of care. So and you're always, especially when you have an epidemic, you're always going to have people that are going to take advantage of that. And we've got a bunch right now across the board.
Talk about legislation, what Trump did with making that opioid crisis, and what that governor from Christie. Do you think that's really making a difference?
As I said earlier, I'm it's frankly, I saw that statement as pretty much it was all form and no substance. We have, we all know it's a crisis. Everybody in this room knows it's a crisis. So there was no surprise to us that he makes this national statement about it. Now, if he'd have put, $150 million behind addressing it, then I'd say, okay, that's it, let's go. But didn't see any of that. I was at the conference yesterday that Chris Christie, or day before, Monday, spoke at, and I didn't stick around. So, obviously, that's my, because I knew that I wouldn't hear anything of significance, other than confirmation of the information that I already know, and that we're in the middle of an epidemic and crisis right now, and so looks like, at least for the time being, we're not going to get any help from the Fed, so we've got to figure it out ourselves.
All right. So some non-addicted patients are profiled because of economics and ethnicity. They face hurdles getting meds for adult ADHD. How do you advise them to talk with their PCP to cultivate trust and be prescribed the meds they need? Wow,
Man, that's probably a little above my pay grade, but I would, again, ADHD is a serious medical condition, and so it is. They should be treated the same. I'm not sure how to counsel them to change that, but that again. We do see that type of thing with people who suffer from addiction as well. So I suppose it's a confirmation that it's not just people with addiction that are having some of these kinds of issues.
So we talked a little bit about the federal context, but I'm wondering if you see any bright spots here in Indiana, since there has been some recent, I guess an effort, a statewide effort, including IU Health and IU and the governor, to address this issue.
Yes.
Do you see hope for, from that?
Yes, thanks. No question. I think Congress, by and large, seems to be moving in the right direction. I know that, for instance, my organization, the Indiana Addictions Issues Coalition, for the past 3 years has had a grant from the Substance Abuse Mental Health Services Administration to train peer recovery coaches, a new paraprofessional in the treatment of addiction, focused on the recovery end of the continuum. A peer recovery coach, and so we have a grant from them, and over the past 3 years we've trained 250 throughout the state of Indiana. And a peer recovery coach is someone, the primary qualification to be a peer recovery coach is that you be a person in long-term recovery. There's no educational qualification. You don't have to have associates or bachelor's or a master's or anything like that. So that's allowed us to train those folks, and also has allowed us to be on the front lines here in Indiana. And our current governor, not our previous governor, our current governor has really, our former governor, who's now in Washington, is very much, very, very fine man and a very religious man. And unfortunately, the conversations my wife and I have had with him, he's very much a moral weakness and personal failing type person. But his number two, who's there too, is not like that. So we also have had the opportunity here to end up on the front page of the national papers with the HIV and AIDS and outbreak piece in Scott County in southern Indiana that has come as the result of prescription drug and opiate crisis from the needle sharing that took place. So the good news is that we got a grant to train recovery coaches. That was the main reason, or we were told, that moved us up to the top of the list when we applied for the grant because of what was happening in Scott County. And we've actually trained 25 down there, and I have a group of 25 more who go down there every week and run groups in that part of Indiana that are recovery coaches. So they're actually working with addicts and alcoholics. So there's some good things that are coming, and I think so. The national attention's on this. There are more bills being introduced in the legislature with money behind them that are being considered. So the federal government's really on board with this. They see this as the crisis, the opiate crisis. But again, it's really elevating this whole issue about substance abuse, addiction, treatment, and recovery. So a lot going on right now. And again, in the 14 years that I've been in this field, it's the most exciting time because they're finally people not only talking about it but doing something about it, and it's been great to be a part of that thing right now. So
great. Well, it's 1 o'clock, so to respect everyone's time, I think we'll close the questions. If you're on the broadcast site and you sent a question, I will make sure that Kim gets that question to get answered.
Sure.
So Kim, thank you so much for coming today.
Thanks so much for being here. Thank you.